Okay, so good afternoon, everyone. Thank you so much for coming today to hear my talk on obesity in the context of chronic kidney disease. And the reason I'm presenting this talk today is, yes, it was working like a minute ago.
Maybe click on the presentation once, and then see if it works. Then see if it works. Yeah.
Okay. So the reason I decided to use this topic was because of this patient of mine who is a really beloved patient, 53-year-old. And I have been seeing her since 2016, but for the sake of this talk, I'm going to start this story in December 2020. So she's 53-year-old at this time, and she has advanced chronic kidney disease. Unfortunately, by this time, she had developed advanced CKD. Her primary pathology was idiopathic MPGN, which was recurrent, and she was seen in December 2020 for a follow-up. She's otherwise pretty good. She has no other significant comorbidities other than just class 3 obesity. Her weight is 124 kilos to 72 pounds, and BMI is 46.7 at the time of this appointment. She received a recent letter from transplant stating that she was ineligible for transplant because of her high BMI. And despite the fact that she has 2 potential life donors, like her sister and her dad, they come to every appointment with her. She lives really far, has to drive around 3.5 hours to reach the appointment. She's already seeing a psychologist and a nutritionist, but all her attempts to lose weight have been unsuccessful. So she's in tears today because she's realizing that she may need to start dialysis soon. And in the past, she has opted for PD when she went for CKD education. So her insurance, unfortunately, has declined to cover bariatric surgery. At this appointment, she's complaining of feeling tired, constant itching, or a sleep-wake cycle, which is interfering with her work. She works as a graphic designer. And her labs show a creatinine of 4.07 and a GFR of 12 ml per minute per 1.73 meters squared. So here is the GFR trend. This is us way back a year ago in January 2020, and we are seeing her here around December 2020. So it's almost like a year difference, and you can see that there is a decline in the slope of GFR over a period of 1 year. So we refer her to transplant surgery for PD catheter insertion. And a few days later, she calls to let me know that her dad is gifting her $10,000 for her to able to undergo bariatric surgery. She's asking if bariatric surgery and weight loss will help her regain some of the renal function back, enough to last until she can get preemptive renal transplant. She does not want to do dialysis. And that begs another question. Did obesity contribute to the faster progression of the chronic kidney disease? So with this case in mind, we will start this talk with the following learning objectives. We will describe the effects of obesity on kidney function. We will understand the mechanisms underlying obesity-related glomerulopathy, and we will explain the impact of weight loss on kidney function. So what is obesity? Obesity is defined as excess number and size of adipose cells. It's measured by BMI. It is actually classified using the criteria for BMI. However, BMI has a caveat. All obesity is not the same. And you have to understand that there is also the distribution of fat, which could be more visceral than peripheral, and visceral fat is associated with poor outcomes as compared to peripheral fat. And a better marker of those distribution is waist circumference and waist hip ratio. There are also ways that you can measure the body fat percentage, more commonly by DEXA, or sometimes in research studies, they would use a plethysmography. So there is a concept called android versus gynoid obesity. It depends on the waist circumference and waist hip ratio. In patients, even if their BMI is normal or BMI could be high, but if they have high waist circumference, which is 102 centimeters in men and 88 centimeters in women, or a high waist hip ratio of 0.8 and more, I think you have seen this, heard about this apple shape and pear shape distribution of fat. So apple shape is more associated with high waist circumference and waist hip ratio, and is associated with poorer outcomes as compared to below the waist obesity or peripheral distribution of it. So this gives rise to a concept which is called hypertriglyceridemic waist. And this was a study which was done in 1998, where the authors compared the traditional risk factors for ischemic heart disease to non-traditional risk factors and came up with a term called atherogenic metabolic profile of the blood not related to the traditional risk factors. And they proposed 3 risk factors, which was elevated fasting insulin, elevated ApoB levels, and small dense LDL levels. And they showed that these non-traditional risk factors were significantly associated with a higher risk of ischemic heart disease. And this is just a cartoon to show what does it mean by small dense particles and ApoB. This is LDL particles which are large boring particles, and each LDL particle has an ApoB molecule here. The small dense particles are smaller and denser, but they are increased in number. So they have, and each one has 1 ApoB, so you have more ApoB now. So the problem here is testing for ApoB and small dense LDL, elevated fasting insulin may not be available on all the labs, and insurance definitely doesn't cover it all the time. So is there any way we could use some surrogate markers for this fasting insulin, ApoB levels, and small dense LDL? And this study published in Circulation showed that actually triglycerides more than 150 milligram per deciliter is a good surrogate marker for small dense LDL, and a waist circumference of more than 90 centimeters is a good clinical marker or screening tool for fasting insulin and ApoB levels. Now, these 2 are pretty much easier to check, at least for screening, and then if it is positive, then could check for insulin and ApoB levels. Coming back to obesity, obesity is common, and obesity means BMI. Okay, we are going to BMI. Most of these studies will be using BMI, unfortunately. But BMI of more than equal to 30, including severe obesity, the prevalence is around 40% of the population. What about the trend? Of course, it is increasing, and most of the increase is seen in people with higher BMI levels than lower. What about CKD patients? CKD patients have a higher prevalent rate of obesity than no CKD. So 49.1% patients with CKD are obese. That's like half of the patients with chronic kidney disease are obese, GFR, BMI more than 35 or 30. So is there something that, we're talking about the, so if the obesity common in CKD, but obesity is also associated with other risk factors of CKD, hypertension, diabetes, namely which are the number 2 causes of CKD in this country. So does obesity have an independent effect on CKD development and ESRD or not? So this study here was published in the American Journal of Kidney Disease, and they used the Framingham Heart Study cohort. And the follow-up period here was around 18.5 years. And they were looking at people who, the sample size was 2,676. These are the patients who have no CKD at baseline, and they followed over 18.5 years, and they found that 212 patients developed CKD at the end of follow-up period. So when they looked at how many they stratified according to weight, overweight, and obesity, and overweight and obesity, and they found that being overweight increased the risk of developing CKD by 29% in overweight patients and 68% in obese patients. But when they adjusted for variables, including diabetes and hypertension, they found that the association was gone. What about proteinuria? So again, the sample size was 2,413. They were looking at dipstick proteinuria. So anything which was trace or more, they called it as proteinuria. And at the end of follow-up period, they found that 347 patients developed proteinuria. And again, when they looked at by BMI stratification, age adjusted and sex adjusted, they found that the risk was higher among patients who had who were obese. And even when they adjusted for hypertension and diabetes, they found that the high risk was there. So increase the risk of proteinuria, but not so much of development of CKD in patients who started with monogenic. What about end-stage renal disease or ESRD? This was a big study from Kaiser. They had like 320,000 patients, and they adjusted this model for, so what the data I'm presenting is adjusted data for age, sex, race, education, smoking, and proteinuria, baseline creatinine, etc. So they found that the risk of ESRD increased as the BMI increased. So the rate was 10 per 100,000 person years in someone with normal BMI versus compared to 108 per 100,000 person years in a person who in the category of BMI more than 40 or plus obesity. And when they adjusted for diabetes and hypertension, the rates remained significantly higher than this one. But this implies that high BMI is a potentially reversible risk factor for end-stage renal disease. And I think it is important to consider more so in this era where we have so many options to lose weight, both surgical and pharmacological. So again, getting back to this study, and I'm going to highlight the diabetes. And when they looked at patients who had diabetes versus no diabetes, in the patients who were overweight, there was higher risk of ESRD, similar in diabetics versus non-diabetics. Class 1 obesity, again, similar versus diabetics and non-diabetics. Class 2 obesity, meaning BMI 35 to 40, again, higher risk of ESRD. And class 3 obesity, the risk remained significantly higher, but among patients with diabetes, they had a slightly or maybe lower risk of development of ESRD than patients who did not have diabetes. Now, I don't know if this was just because of the sample size, because patients who had class 3 obesity or morbid obesity at this point and did not have diabetes, the sample size is so our first learning objective was to describe the effects of obesity on kidney function. And we discussed that obesity is common and affects half of our CKD patients. BMI may not be the best tool to assess obesity, but it is the most commonly used tool. High BMI is associated with higher risk of proteinuria, but not development of CKD3, above and beyond the risk associated with diabetes and hypertension. High BMI, however, is associated with higher risk of end-stage renal disease independent of hypertension and diabetes. So maybe we do know that it increases the risk of proteinuria. I don't know if the CKD development did not show a significant association because the sample size was smaller in that study, only 2,000 patients, versus in the other study, which had 320,000 patients. But having said that, it remains that high BMI is a potentially reversible risk factor for end-stage renal disease. So how does obesity cause chronic kidney disease or contribute to chronic kidney disease? So this group of authors started to look at the filtration dynamics in patients who were obese and then and control patients. So these are volunteers, healthy volunteers. They don't have any hypertension or diabetes. They don't have normal creatinine. They don't have any proteinuria. The only difference in the control and obese group is their body weight. And there were 9 volunteers in the control group, and there were 12 in the obese group. And here, you can see, and they measured the GFR by inulin clearance, and they found that the people who had the gray bars are the control group, and you can see they had lower GFR than people who were obese. And so you can see in the control group, the GFR was around 90 by check by inulin clearance. And in the obese group, the GFR was around 136 ml per minute. Here, the authors did not use they did not use the body surface area to determine the GFR. And this is another caveat in these studies. You will realize that when people lose weight, their body surface area decreases, but their number of nephrons is not changing, right? So when you are determining the GFR per body surface area, then you're not measuring the single nephron base. But most studies will report GFR in these studies as to adjusted to body obesity. But this study did not look at single nephron GFR. And so higher GFR in obese group, and there was in patients who were obese had 51% higher GFR. They also looked at renal plasma flow, and they found that people who were obese had higher renal plasma flow by 31%. So the increase in GFR is not solely explainable by increase in renal plasma flow. There must be something else going on. So there are three determinants of GFR. So one is renal plasma flow. The other is a transcapillary pressure gradient. Now, this paper says, I'm not an expert on this, that the transcapillary pressure gradient has the hydraulic component of it, or hydrostatic component of it, is not directly measurable. So they had to indirectly measure it. So they looked at the oncotic pressure gradient, and they found that it was not significantly different in the two curves, and they deduced that most likely it was the hydraulic pressure gradient which was different. Because the ultrafiltration coefficient, the third parameter which determines the GFR, was also not different between the groups. So in these patients who are obese, their GFR was high, partly because of increase in renal plasma flow, but also increased by transcapillary hydraulic pressure gradient. Now, this gradient is determined by the tones of the afferent and the efferent arterioles. So there was difference in the tone of the afferent and efferent arterial tones enough to increase the hydraulic transcapillary pressure gradient as well. So how is this different from hyperfiltration in diabetic nephropathy? In diabetic nephropathy also there is increased GFR, and again to some extent there is increase in renal plasma flow as well. But in diabetic patients, in the hydraulic pressure gradient and the oncotic pressure gradient doesn't change, it's the increase in ultrafiltration coefficient. So their pore size is different in patients who are diabetic nephropathy, but in patients who have obesity-related glomerulopathy, they have a normal pore size. So how does it look under the microscope? This was a study which was also kind of a landmark study conducted at Columbia, and this was from the Department of Pathology, and they looked at 71 patients, 71 kidney biopsies. And they found that these patients had two kinds of morphology. One was obesity-associated FSGS, which was secondary FSGS. They could see that there were something called diabetoid changes, meaning there was GBM thickening and mesangial expansion. And there was FSGS, but there was focal segmental glomerulosclerosis, but there was minimum podocyte or food process effacement. Again, very characteristic of secondary FSGS. But the most characteristic difference what they found was something called glomerulomegaly, or there was marked glomerulomegaly or obesity-associated glomerulomegaly. And the mean glomerular weight was 226 micrometers in patients who were obese, as compared to 169 micrometers in patients who were not obese. And these are age and sex match control. And just to add a similar quantification, you can see how big the glom looks in patients who are obese. This is another example just to compare the size. Same magnification, 400. This is obesity-associated glomerulomegaly. This is post-infectious and ANCA-GN gloms. And this glom, you can see how full it is. I mean, the capillaries, the endocapillary proliferation, fibrin, necrosis, and all. But the glomerular size is not increased as compared to obesity-associated glomerulomegaly, where the glomerular size is really big. So that is one of the striking features of obesity-associated glomerulopathy. Occasionally, under electron microscope, you can also see fatty deposits or lipid droplets in the. This is a cytoplasm. This is a podocyte. You can see the food processor, which is cytoplasm of the podocyte, and you can see the lipid droplets here. And these are mesangial cells. You can see that sometimes. So in essence, there is obesity causing chronic kidney disease. There is glomerular hyperfiltration. There is insulin resistance, lipotoxicity. There are the hormones, adiponectin, leptin, this ectopic lipid causing lipotoxicity, inflammation, scarring, all the cytokines involved, finally leading to chronic kidney disease and the mechanisms that we just discussed. So our second learning objective was to understand the mechanisms underlying obesity-related glomerulopathy. We discussed that GFR is 51% higher in obese patients than those with normal BMI, and it is by increased renal plasma flow as well as increased hydraulic transcapillary pressure gradient. And the ultrafiltration coefficient pore size were not affected, contrary to diabetes. We learned about the pathology, the diabetic changes, a high or increased glomerular diameter, and thus podocyte proliferation. Any questions so far?
It's changes at Lavazio.
Hmm?
It's changes at Lavazio. On the number of you have in this that no longer can be really good conflict. These are Lavazio on the
Reversible? I don't know. That's a good question. I think we should look into that. I didn't see any studies as to who looked at reversible pathology findings.
There was one study that did a biopsy after extreme weight loss. So maybe, did you present it at one time or long time
a
ago?
long time ago.
Yeah, maybe like 10 years ago, there was a study in
Good memory.
the New England Journal of Medicine or something that you know, it's hard to know with the biopsy whether you're really reversing or it's sampling, but there was some clue that some of these are reversing.
Yes.
States that you were talking about the intraglomerular filtration and obesity, did they consider intra-abdominal pressure and how did they, because intra-abdominal pressure obviously is a very important factor in glomerular filtration. And it depends on how the patient's position is, obviously being laid down, supine position, and abdominal pressure goes higher. And that type of, did they even consider that?
They did measurements in supine position for sure. They saw that, but they did not measure the intra-abdominal pressure for sure. Ultimately, if it's going to affect the hydraulic pressure gradient, maybe it did. The fact remains that due to any reason, the hydraulic pressure gradient in patients who were obese was higher than in patients who were not obese. So moving on to the treatment options for obesity, there are lifestyle changes, diet and exercise, and there is bariatric surgery, and then there are drugs such as, I'm going to talk about GLP-1 receptor agonists, but there are other drugs as well. Usually for short-term use, like there's a combination of propionate and phentermine and other drugs, but I didn't look into that with this. So let's look at the lifestyle changes and start there because that should always be the foundation of any weight loss regimen, I think. So there was this study which looked at impact, the community-based weight loss program on nutrition. So this was done in Kansas, and this was a retrospective study. This center has a very dedicated obesity management program. So they do intensive lifestyle intervention, meaning they are eating weekly, they are putting the patients on 800 kilocalorie dietary restriction, calorie restriction. They are doing 150 minutes per week of intensive exercise. And then at 12 weeks, they looked at this. And so they had 71 patients, and 73% of these patients had a very high BMI. All of them were obese, but 73% had BMI more than 40. And their average GFR was 47 at when we started. And they found that as time progressed from 0 weeks to 12 weeks, the weight is in blue. You can see they started around 290 pounds, and then they decreased by this intensive lifestyle intervention. They were able to lose weight to 60 pounds, so almost 30 pounds weight loss. And then they looked at GFR, starting at week 0, it was around 47. And then by 4 weeks, not much difference. There was some, it was increasing, but by week 12, they found that the GFR had increased to somewhere around 53, 54. So again, short-term study, 12 weeks only. Is this weight loss maintained and is this GFR maintained? It's hard to say. Yes.
Is this creatinine based?
Yeah, yes, they're all creatinine based GFR.
Like, how did they know it was a muscle mass loss, like 3 months?
And second caveat of these studies is using creatinine based GFRs. So, so how effective is this intensive lifestyle intervention in losing weight? So this study was called Look Ahead study, and they looked at 4-year data of intensive lifestyle intervention, and they wanted to see how much weight the patients lost and was this weight loss maintained for 4 years. So for first year, they randomized patients into intensive lifestyle intervention, around 2,400 patients, and the similar number of patients in DSE group, which was diabetic support and education. So the difference was in ILI, they met every week with the patients one-on-one or in a group, and they told, educated them about, they took their dietary history, they are like, and they're focusing on 175 minutes of exercise weekly. And then for the support and education, they met 3 times in 4 years. And they just didn't do much, just general education. So these were all obese and diabetic patients. And in this study, 36.3% of patients lost more than 10% of their initial body weight at year 4. So this is year 4. These are 36.3% of patients. These are all patients who lost at least 10% of their body weight at first year. And then they are looking at how many patients maintain that weight at year 4. And only 42.2% of those patients, out of those initial 36%, were able to maintain their weight loss at 4 years. Again, with intensive lifestyle intervention ongoing for 4 years. The average weight loss at 4 years was 4.7%. So if you start with like 270 pounds, even for the 4, if you start with say 100 kilos, so 4 kilos, 4% would be you weigh 96 kilos at the end of 4 years. With intensive lifestyle intervention, that doesn't really change your BMI much. So it is very intense. It should be done. It's hard to do and is not very successful in terms of absolute weight loss and maintenance of weight. I did not see any study of like long-term weight loss by diet and lifestyle changes in GFR. I think probably because it's just so hard to maintain the weight loss over long term. I think it's just so hard to do ILI for long term as well. So what about bariatric surgery? So this study was published in 2017. Again, it was a retrospective study. They had 714 patients who underwent bariatric surgery, and they compared them with 714 controls who did not undergo. They were referred for bariatric surgery, but they did not undergo bariatric surgery. They looked at the primary outcome was a change in eGFR over 3-year follow-up. Again, creatinine-based estimations. So what did they find? So this is estimated GFR. So this data is before matching. So I'm just going to focus on after matching. Again, 714 patients. You can see the population. Their average age was around 58. Their weight was around 70 pounds. Their BMI was around 40. 77% were women. A lot of these studies, mostly women predominantly. And then hypertension and diabetes, 90% patients had hypertension and 65 to 68% patients had diabetes. Average creatinine was 1.4 to 1.5, and average GFR was around 47 to 48. So now they are looking at difference in GFR after weight loss. This is surgery versus control, and they're looking at different months, 3 months, 6 months, up to 3 years. So we're going to look at the adjusted estimate here. They are adjusting this for GFR at baseline, age, sex, race, hypertension, and diabetes. So the adjusted estimates of surgery versus control, this is, there is a change in GFR in the positive direction by 12 ml per minute for 1.73 meters squared at 3 months. It was sustained until 24 months. At 36 months was also sustained, but the magnitude was 1. Same thing, they looked at different kinds of surgeries, Roux-en-Y versus a sleeve, and they found that the Roux-en-Y had more GFR, more increase in GFR as compared to sleeve gastrectomy. So this is a meta-analysis. Now that was a retrospective study. This was a meta-analysis. They looked at kidney function after bariatric surgery. And in this study, they included studies which had patients more than 18 years, BMI was more than 40 or 35. They had patients who had CKD3 and beyond. And they included studies if they had post-surgery measure of kidney function. There were 19 studies they were included. The total number of participants were around 4,600. 67% were women, age was around 46 years, BMI was 42.3. Again, they looked at the effect of bariatric surgery on BMI. How effective is bariatric surgery at using that? And the main difference here in this is the pre-bariatric surgery rates in different studies and post-bariatric surgery. These are BMIs in different studies, and they found that the average mean difference in BMIs pre and post was 11. It is pretty significant, I think, right? The duration of follow-up here was very heterogeneous. It was from 6 months to 13 years in one study, but most studies I saw was 3 to 4 years. This was meta-analysis.
None of them are randomized.
Oh, some of them were randomized, some of them were, they definitely excluded all the reviews and case reports and all. But some of them were restricted. So the mean difference in BMI was 11, which is pretty significant, as you can see by this forest plot here. And this is serum creatinine before and after the surgery. The mean difference here was in 0.24, and the creatinine decreased by 0.24 post-bariatric surgery, and this was significant. And they looked at eGFR before and after surgery, and the eGFR increased by 11.6, the difference in eGFR. So it increased by 11.64 in patients after surgery. Stage 3 CKD, they're looking at risk ratio, and it was not significant. So it didn't really change the CKD staging. May change GFR, but not by as much to change the CKD staging. They looked at proteinuria before and after surgery, and then they found that the risk ratio was, the reduction was 3 times after bariatric surgery.
So in memory of your Dr. Johnson, did they look at uric acid? Because uric acid you'd expect to decrease after bariatric surgery, and that could have profound effects on GFR.
Yeah, I did not. These studies didn't actually. So, this was improvement in patients who had CKD. This population was all patients who had GFR less than 60. What about in patients who have normal GFR? So in this meta-analysis, this was done at Kaiser, and there were 49 studies. They were included. There was no GFR restriction. All kinds of GFRs were included in the study. And then there were 8,000 patients. Again, follow-up was very variable. And then GFR analysis included 27 studies with 3,100 patients. So this was a forest plot comparing GFR between pre and post surgery. And there was no difference. 3.08, but it was not clinically significant. So then they stratified in patients with GFR less than 90, 90 to 120, and more than that. And they saw that patients who had GFR less than 90, they had a significant improvement in GFR. Patients who had GFR between 90 to 120, not significant. In patients who had GFR more than 120 actually had a decline in GFR. So that's why the total was, not significant, but when you individually look at different groups, it did show significant. So the GFR increased by 13 in patients who had GFR less than 90 to begin with. And it was clinically significant, again, not significant here, and then more than 120, the GFR declined by
Which may be beneficial.
which might be beneficial.
You received that one, you see less hypertension, right?
Yes,
Hypertension.
exactly.
That's not a.
So this is a forest plot comparing incidence of albuminuria between pre and post surgery, and again, the confidence interval was significant in this case, and the risk ratio was reduced. It was 0.39. So far, it seems that lifestyle intervention works, in bariatric surgery works, but bariatric surgery has just a higher magnitude of weight loss as compared to in the lifestyle intervention. Now, how long it is sustained is also debatable, but up until 3 years, we did keep sustained GFR improvement and decline in hyperfiltration, which was a big thing. So what about GLP-1 receptor agonists or antibodies? Award 7 trial. So this trial was conducted, it was an open label, randomized, multi-center trial. They had 99 sites over 9 countries, and they included all adults with type 2 diabetes. And they all had CKD stage 3 to 4. Their A1C was between 7.5 to 10.5%, and they were on maximally tolerated dose of ACE. So they had a total N of 577. And they randomly assigned these 577 patients to 3 groups. 193 went to dulaglutide, which is trulicity. I so hard to pronounce dulaglutide. It was 1.5 milligrams, and then 190 to dulaglutide of 0.75 milligrams, and 194 were assigned to insulin reaction. All of these patients received the short-acting insulin to be able to tightly control the A1C. The primary outcome of this trial was to look at A1C, change in A1C from baseline to week 26 and week 52. And the secondary outcome was to look at change in eGFR. CKD epi, they looked at, this was one study that looked at cystatin C, but not combined with creatinine and cystatin C or creatinine. They also looked at change in albumin creatinine ratio and the body weight at 26 weeks and 52 weeks. So looking at this, this is the dulaglutide 1.5 milligram, the 0.75 glargine, just to see the baseline characteristics of these patients. Again, 46% were women. They all had been diabetic for around 8.5 years. Their A1C was around 8.5 to begin with. People who had more than 8.5, A1C was 50%, 14%, 22%. Blood pressures were, the BMI is 32 to 33. The systolic blood pressure is around 130, systolic is around 70s. They're getting around more than 50 units of insulin per day. And then they all had chronic kidney disease, remember stage 3 and 4. They excluded patients in this study with GFR less than 11. So they had CKD for around 3.5 to 4 years. So their eGFR on average was around 38 by creatinine. And then they stratified these patients by baseline GFR more than 60 to less than 90, 45 to less than 60. So most of these patients had GFR here, 45 to 60 and 30 to 45. So I don't know, they said they excluded all patients with GFR less than 11. So I'm thinking maybe this is somewhere between 11 to 15. And they also said that they only included patients in stage 4 and 5 CKD. So I don't know if they didn't include these in the final analysis. This was a secondary outcome, so it probably. So they looked at GFR by cystatin C again, not much different, 37 and 38. And again, the same thing. They also looked at the albumin creatinine ratio, normal microalbuminuria and macroalbuminuria. 44% patients have macroalbuminuria in this case. More than 90% or 94% of patients were on menin system. So again, same thing which I probably showed you in eGFR by creatinine and cystatin C. I think I wanted to highlight that it was not much different when we measured with creatinine and cystatin C in these patients. Differed by 1, but the creatinine GFR was slightly higher. Again, these are all of these patients. So what happened at 26 weeks and 52 weeks? This is looking at the weight change. And at 26 weeks, you can see this is dulaglutide 1.5. There is weight loss within the weight loss with dulaglutide happened within the first 4 to 5 weeks, and then kind of maintained up to 2 years later. The weight loss was more with higher dose of dulaglutide than with a lower dose, but there was actually weight gain by insulin glargine, which is not even unexpected. So this was all significant. These patients have the weight loss. So it does it so weight. So the degree of weight loss was around 3 kilos. So not as much as like what bariatric surgery achieved, but definitely better. And nowadays, I think we have newer GLP-1 agonists which have more sustained weight loss and more magnitude of weight loss than the so the eGFR changeover time, this is by cystatin C and this is by creatinine. And again, it is per 1.7 meters square, adjusted for body surface area. This is 26 weeks, this is 52 weeks. So blue is dulaglutide 1.5, and by cystatin C at 26 weeks, there was GFR, increase in GFR in patients on dulaglutide 1.5 as well as 0.75, and decrease in GFR in patients who are on insulin glargine. Same thing with creatinine equation as well, same thing at 52 weeks and 26 and 52 weeks. So there was GFR improvement in GFR by statin C. You looked at creatinine, however, the GFR actually was lower, but not as lower as with patients who are on glargine. It always does that. It starts in like 15 minutes to end, and it blows 4 days. So kind of confusing data, right? I mean, there is improvement by statin C, but not so much improvement by creatinine. However, in the creatinine group, there was less decline. So overall positive, I would say, but it kind of gets back to the point of creatinine estimation and the limitations of GFR estimation by creatinine. So what about GFR when it's stratified by presence of macroalbuminuria? So in patients who had 26, so this is in patients who had macroalbuminuria baseline. Remember, around 40% of patients had macroalbuminuria baseline. And this is at 26 weeks, and this is at 52 weeks. And again, this is the 1.5 dose green is insulin. So they found that among the patients who were macroalbuminuria, insulin levels definitely caused significant decline in GG. That's not a good thing. But in patients with who were on dulaglutide, the eGFR significantly improved, but not by as much that we were seeing with the bariatric surgery. In patients among who did not have macroalbuminuria, there was benefit, but not to the same amount. So, with regard to our third objective, we learned that lifestyle intervention improves GFR in short term, but difficult to achieve target weight as well as to maintain the weight loss in the long term. Bariatric surgery is very effective in weight loss. It improves renal function in those with GFR less than 60 and decreased GFR in those with hyperfiltration. The effect is maintained for 2 to 3 years, and bariatric surgery improves proteinuria as well. GLP-1 receptor agonist, GFR decline was slower at 52 weeks with dulaglutide, especially in patients who had macroalbuminuria. So coming back to our patient. So this is her weight loss. This is how she weighed in 2016 when I started seeing her. Around 260 pounds for her versus weight, even when I was seeing her. And over the years, when she had finally underwent the bariatric surgery, her weight had gone up to 273 pounds. Some of them was also fluid weight, but most of it was liquid. And then she had the bariatric surgery here. You can see the precipitous decline in weight loss at different time intervals. Her nadir weight was achieved 10 months after the bariatric surgery, she went down to 202 pounds. So she lost around 70 pounds of weight, which is around 3 kilos. Approximately, and over the years she has started to gain weight. So this is now in 2024. She is like 222 pounds now, but she maintained her weight loss probably for around a year. So what happened to her creatinine? This was 4.07 when I saw her. Then this was, I don't know, this was not a good thing. Then here is where she had the sleeve gastrectomy. And then the creatinine went down and then stayed more around 2.4, 2.6, 2.7, 2.3. And EGFR, again, when I saw her, GFR was 12. And then this GFR is this creatinine here, which was kind of flawed. So ignore that. And so it kind of increased, some declines. And you know what is it? This is the statin CGFR. I don't know what happened. This was Quest Lab. The cystatin CGFR was 51 at the point when her creatinine GFR was 17. So I was like, I don't believe that I'm in the middle of 24-hour event. So I did a 24-hour creatinine urea clearance. It came out to be 17, which was exactly the same as ml per minute. But when you adjust for body surface area, it was 15. So definitely an improvement in GFR. I mean, 3 years ago, she was ready to go on dialysis. And today, she's still not on. She's still getting there, and her transplant situation, unfortunately, did not work out. She's on the list.
Did you have like 24-hour GFR or cystatin CGFR before surgery? It's hard to compare, right? Like, how do we know how much is the muscle mass here versus how much is actually improvement in kidney function? Just for the sake of I agree that obesity treatment is always good, irrespectively. Anyhow, if you go for transplant or not, but I'm just trying to figure out how much is the muscle mass are we talking here? Because they stopped eating, right? After surgery,
she stopped eating and she lost a lot of weight.
Right.
And but having said that, I mean, clinically also, she was at the point where she did dialysis 3 years ago, and she's at a point right now and she doesn't need dialysis.
But that's just number you're talking, right? I mean, that's the creatinine based number.
No, she was symptomatic. And
Okay.
and so she had, like probably sleep wake cycle, she had severe pruritus, she had fatigue, tiredness, she could not work at all. And right now she's fully functional, she's doing a lot of things in the
Losing 70 pounds helps with that.
yes, that is big.
I mean, losing weight is good.
Losing weight
General.
for so many.
So I have a question. I don't know if you have another.
I think this was some challenges, for all of us, not enough resources to do intensive lifestyle intervention. I mean, I think that if this patient had bariatric surgery and then had some lifestyle intervention after that, she would have been able to maintain her weight. But it's not easy for us to do this in our nephrology clinic, and there are not enough weight loss clinics, obesity management clinics like in Kansas City, where they did this study. Insurance coverage for bariatric surgery is on all of pocket costs are very high. This patient got fortunate that her dad gave it to her as a Christmas present, but how many times has that happened? Prior odds for GLP-1 agonists. I know Sabrina is already drowning with SGLT2 inhibitors, so she'll kill me if I GLP-1 agonist. Drug shortages, even if you order it, you can't get it. And then long-term effects of GLP-1 agonists. Nowadays, there are a lot of studies. We know that once you stop the GLP-1 agonists, the weight comes down.